Huge studies have shown if you got multiple scans done over a period of say 5 years even, your risk of developing cancer went up by 2%. People refusing to do a scan and then coming into the ER with a heart attack where 30% of their muscle is gone, they're incapacitated for life just because somebody told them don't do a scan because of the radiation. We are at a situation where we have about 25% of our population to have metabolic syndrome. So today, if I don't do a CT angio, worried about the radiation bit, and I have coronary artery disease, and I develop a heart attack, what was the point of me worrying about a cancer which might come 2 decades later? And if it was so bad, our hospitals would be full of cancer patients. It happens to marathon runners. It happens to people who go to the gym regularly and are fit and looking fab. Steve Jobs, that's what exactly happened. He went for a CT for his kidney stones and they picked up a neuroendocrine tumor. You have silent diseases which creep up. We have a high burden of cardiovascular disease. We get it 10 to 15 years before the Westerners. I see coronary artery disease silent daily.
If someone listening to us right now could do just one scan that they have never done before, what do you think they should do? Dr. Anirudh Kohli is the CEO of Breach Candy Hospital and one of India's top radiologists who has spent decades looking deep inside our bodies to find things that are silently lurking. In this incredible conversation, what I realized is that we cannot just do blood tests to understand what is happening. This episode is the Bible for preventative imaging. Prevention is 1,000 times better than cure. And this episode takes you through the right scans that you have to do to prevent massive problems in the future. The visceral fat that you cannot see in the mirror, the plaque in your arteries that no blood test catches, the aneurysm in your brain that may have been sitting there since you were born. What to scan, when to scan, and why an executive health checkup is just not enough today. You can either know what is inside you or you can keep guessing. Watch this till the end. Let's just pause for a moment. Now, some people like quick answers, while some people like to think deeply. If you're in the second group, the secret sauce is made for you. So please hit subscribe. Who are you and what do you do?
Thanks, Mukul, for having me here. Well, I'm a medical doctor trained in radiology, which today we call medical imaging.
Right.
Basically, it's photographing your insides and picking up diseases or saying everything is good. I've done that for 35 years. When I came in, there was basically CT scan. There was no MRI. Learned MRI, and we were fortunate to start the first really private MRI in the country at Breach Candy Hospital. And I've been looking after the radiology department at Breach Candy. And about 3 years back, I don't know whether a little bit of a middle-age crisis or what, I decided to extend and go into administration. Firstly, I was for a year as the medical director at Breach Candy Hospital. And then for now, last 2.5 years, I've taken over the position of CEO of the hospital.
I know, amazing. Congratulations.
Thank you.
How does it feel?
It's tough.
It's tough, I know.
One, handling both because I'm enjoying both.
Right.
So there's no way that I'd want to cut back. So obviously, time is compromised in the sense I have much longer working hours. And also the admin role brings on a lot of responsibility. Because at the end of the day, the buck stops with you. So that's where I am and I'm enjoying it.
And you're also the editor of the radiology journal?
I used to be.
I see.
It is a 3-year post.
Right.
And I think I ran it from 20 to 23, 3 years.
Got it.
The editor of the Indian Journal of Radiology.
Can you tell us a little bit more about that?
So it's the official journal of the Indian Radiology and Imaging Association. So it's peer-reviewed journal.
During your time, what was the most interesting thing that happened in those 3 years?
One was, of course, that my focus from the editorial point of view was pushing newer technologies. And then, of course, we had the COVID pandemic. So
Right.
A lot of focus then went on imaging and the COVID pandemic.
Heart, lungs.
Mainly lungs.
Lungs.
Yeah. So, in fact, one of the first editorials I wrote in April of 2020 was that it's basically a pulmonary problem, and the CT scan is so good at looking at lung parenchyma, and maybe CT might become a public health tool. Obviously criticized, but 1 year later, everybody needed a CT scan done. And a year later, when we had the second wave where we had CT was being used and we had such a huge flux of patients, we actually did a very good study at Preventive Hospital where the problem about COVID was very simple. Today you have an OPD 300 people coming. At COVID you had 5,000 people coming. What do you do? Who do you admit? Who do you send home? What type of treatment? So we actually looked at CT scans done 7 days to 10 days after the fever began. And we were able to correlate and say that if we created a CT score out of that based on the percentage of lung involvement, the density of lung involvement, things like that. And we were able to predict that these patients could go home.
Right.
These patients would need to be admitted. Within those patients who were admitted, who would need ICU care, who wouldn't. Further, we were able to predict who will benefit with just room air, who will need low flow oxygen, high flow oxygen, and who would need intubation. Why? Because the most important point at COVID time was because of the number of people, you had to triage, decide quickly who goes where, what.
Yes.
So you go to a COVID center, you go back home, this, that. So that was a very good paper. But as you know, publications take a year by the time they're peer reviewed and things like that. So of course, final dissemination of that came close to the end of the COVID pandemic. I hope that there's no second pandemic, but if it is, it might be very useful at that time.
Right. You've been doing imaging, both preventative and of course post-symptom. But we really want to focus on preventative because that's something that you are deeply interested in. A lot of people do blood tests, but not enough people are doing preventative imaging, scans of sorts. So we want to get into that with you deeply.
Where we need to be in the space is that you have silent diseases which creep up on you. And the only way to detect silent diseases is to have preventive evaluation, whether it be blood tests or imaging and things like that. But of course, everything has to be balanced out because everything's got its pros, cons, things like that. So we need to carefully look at cardiovascular disease. That is a silent killer. It can be manifest and give you not much time to react. So we are at a situation where we have about 25% of our population to have metabolic disease, metabolic syndrome.
25%.
25%. And this is also across Asia. I see coronary artery disease silent daily. Every day, people come in and they sometimes come with non-specific symptoms. I have a little bit of gas or I had this thing and somebody says, get a CT angio done and then okay, we'll get it done. And you have triple vessel disease. Right. I mean, I remember Dr. R.P. Sunawala. He walked up to me and he says, you know what, nowadays I run up the third floor and I get a little breathless. What do? I said, get a CT angio done. No. 1 week later, I met him. He says, I'm thinking about it. And I'm walking at Dubai airport. I was walking a little fast. I felt a little breathless. Well, get a CT angio done. He said, you told me that later. Okay, come, I'll do it. Did it. 2 days later, Bhattacharya did a bypass on him. Oh. So, there is very minimal symptoms there could be. There could be no symptoms. There could be symptoms being ignored. Symptoms being missed as something else.
So what does one exactly, because of the range is so vast, everybody has gas also nowadays, and gas and the heart thing are identical because you have this pain here. I work out, I do push-ups and I feel pain in my chest and it's like, what is it? But then when does someone go for a CT angio?
So I think we need to understand where all this is coming from. As I said that we have metabolic disease. Why do we have metabolic disease? Because we have what we call a thrifty gene. We are basically an agriculture-based civilization. And in agriculture-based civilization, compared to the West, used to have high-energy food, meats, because of the winters that they have, which has been over centuries at risk of famines, floods, natural things. This year, poor crop, bird infestation.
Too much rain,
Too little rain. So there is no consistency in the food production. So over the years, the body genetics, as you know, keeps getting mutations over
Evolving.
times with the environment control. So we have a thrifty gene protect us, which when there are times of abundance, fat is stored, energy is stored. And the easiest place to store energy in the body is in the abdomen. Now cut the scenario and move to this century, where there is basically abundance now, because you have alternative. If there's a famine, there's alternate food. So you have food coming in, not getting burnt off. What happens? Gets deposited in the abdomen. And when I say in the abdomen, it is what we call visceral fat. And what this does, it causes what we call insulin resistance. So it doesn't allow insulin to work well. And then this leads to a cascade of hypertension, elevated LDL, elevated ApoB, triglycerides. You get liver fat stored in the liver. You get fat stored, in different ectopic areas. And then once you have insulin resistance, leads to diabetes. So let's look at the different testing mechanisms for this, because people are using them. You have 3 groups of testing mechanisms for your fat. One is the machines that you have in the gyms and people have at home, which are the bioimpedance machines, where you hold on to this thing.
It doesn't seem very accurate, no?
It's very inaccurate.
Right.
It's dependent how much water you had, how much you haven't, whether you peed, not peed.
Yeah.
So those are really something not to go by.
Yeah.
And then we have 2. One is the DEXA, which is famous for detecting bone density, osteoporosis, osteopenia, but it gives you body fat analysis. And fairly good, fairly accurate. So it tells you about your regional fat distribution, things like that. But more importantly, it gives you your visceral adipose tissue.
Right.
And then you have CT and MRI. Now, DEXA tells you your visceral adipose tissue by a calculated mechanism. So it's accurate, but not perfect. What is perfect is CT and MRI, because you actually see the visceral fat.
Right.
So you can actually measure the extent of visceral fat. And what we do is just on one section of a CT or one section of an MRI, the visceral fat is mapped out, the subcutaneous fat is mapped out. We have AI tools now which do it for us automatically. So it's become easy. There's no real manual intervention in that. And that gives you a direct number. And I'll tell you what the number is. The number in West is considered to be 100 centimeters square of visceral fat as a cutoff. We, being smaller individuals, leaner individuals than the West, the cutoff is considered 80. So anybody with a visceral fat more than 80 centimeters square is at risk for metabolic syndrome, which means he's at risk. So that's where preventive imaging has to come in. At some stage, we must start looking at people who are in their 30s, when the risk of metabolic syndrome starts, when they are out starting to work and now less physical activity and things like that, either getting a DEXA scan, which is very low radiation, as good as no radiation, may be a very good starting point. Or if somebody has a very high family history, risk.
Or is overweight.
Already,
visibly overweight.
Then start with the CT, get an accurate figure, get a DEXA done, use the DEXA then as a baseline, because you can't keep doing CTs or you can't keep doing MRIs. So use DEXA then as a baseline to see how you are doing, whether you're reducing your visceral fat or not. Today, the key problem, I'm simplifying it, but I think it is simple, is visceral fat. Because that is the start for all the entire cascade of problems.
Got it.
My recommendation is very simple. We are the diabetes capital of the world, 25%, which is like a crazy figure. If we were 50 years back and we had this knowledge, we could have instituted across to do DEXA scans or whatever to know the visceral fat, cut down the visceral fat. We would be at 5% diabetes level. So, and very important preventive. And you see the impact, 25% of the population having diabetes, repeated tests, possibility of numerous diseases happening, cardiovascular disease, the cost of medicines, cost of hospitalization, cost of all that. So, the whole idea of preventive medicine is to pick up things early, do modifications, treat, so that you're not looking at huge hospitalization costs and cut down on working time and things like that.
So pretty much all Indians should at least do a DEXA scan to check their visceral fat.
I feel
from
so.
30 onwards.
I feel so. Definitely.
Makes sense. Very low radiation.
Yeah.
And if you know you have visceral fat, you may be overweight, you may not be overweight, but you don't know if you have visceral fat. Then from now only you can start working on it.
Yeah.
At whatever age you are watching this podcast, whether you're 30, 40, 50, 60.
Yeah.
Find out your visceral fat.
Yeah.
Got it. So, Doc, the typical ones we heard about are ultrasound, X-ray, CT scan, MRI, PET scan. Could you take us through these?
Sure. So everything started, my livelihood started 130 years back by Mr. Ranjan, who discovered X-rays.
Got it.
So X-rays are still relevant 130 years ago. Where are X-rays relevant? The chest. It still stands out as a very useful and good investigation. When you're looking at finer details like saying things like interstitial lung disease and small nodules, yes, a CT is better. But the chest X-ray stands out. The spine, to know spondylitis, basic things, it's still very useful.
Skeletal things.
Of course, for fractures, injuries, arthritis to some extent is where. Rest, it's unfortunately lost its relevance, because as technology has moved ahead. The second real investigation which came in was sonography, based on a very simple principle that sonar sound waves were used to measure the depth in oceans. And then it became a possibility that let's look at it where we send a sound wave into the body and different tissues of different thickness, stiffness, density will reflect the sound wave back in a different way. And convert that into an image. And it's become such a fantastic modality, sonography. Very affordable, very good in the neck, blood vessels, thyroid. Not good in the chest. Very good to look at the outer covering of the chest, the pleura, people who have fluid in the chest, you can pick that up. But lung parenchyma, the mediastinum, you can't see. So that's a blind area there. The abdomen, liver, pancreas, spleen, and it's a quick study, easily available. We have clinics every road which will have a sonography. And then, of course, for the females, the pelvis, obstetrics, as well as gynecology, very useful. Looking at the bladder, looking at prostate, enlarged prostate. So these are great values of sonography. And then sonography, as it went on, it got a new addition known as color Doppler, where you could look at the blood vessels. So you can look at the blood vessels other than for the brain. Some people do transcranial Doppler, but generally across the body, you can evaluate blood vessels.
Right.
So this has become a great utility. And then very important for women is what we call a sonomammography. Because when you're young, you have dense breasts. So the mammograms may not be that effective. So you need to couple it with a sonography. You may have a density seen on a mammogram, which you need to decide, is it fluid or it's solid? And that's where a sono helps. Moving on from sono came the great addition known as CT. In 1971, Hounsfield and brought in, and Ambrose, his partner, brought in CT, which has created our livelihood. And it's been fantastic as the technology has changed over the years. We had routine CTs, then we got spiral CTs where you scanned in a volume, you weren't missing tissue. You got multi-detector CT, then you got dual source CT when we started looking at cardiac imaging and wanting to see the coronary arteries, where you had two CT scanners in one.
What is a CT scan?
So CT scan is really a refinement of an X-ray. It's an X-ray source, of course, not as much as the X-ray itself, but a much finer source. And the point was very simple of how it's filled. I have got an X-ray plate. It's got information. If I can computerize this, I can further refine the pixels in it. There must be much more information. And can I, rather than getting a single 2D image, can I get a 3D image, a volume image? And that's what he did. So CT is really a refinement on X-ray where you're extracting data which is already there. And today we have photon-counting CT, which is a further refinement within CT technology where on our routine scans, we converted X-ray to light. And then after it passed through the body, based on the light coming through, it was converted to an electrical signal. So there's loss at every step. Photon counting CT converts the X-ray directly to electrical. And that's why it's so much more superior than routine CTs.
So everybody should, and this is there in all the good hospitals now.
Photon counting CT, it's new, it's expensive. Only 2 hospitals in Mumbai have. And these 2 hospitals in Mumbai are the only 2 CT scanners between Dubai and Singapore.
Oh.
So, yeah. So
which 2 hospitals?
Breach Candy Hospital,
of course,
and Reliance Hospital.
Those only 2 ones in India, therefore.
In India.
In Asia almost.
Yeah, it's good. Between Dubai and Singapore.
So between Dubai, Singapore, India, Sri Lanka, this whole belt.
Yeah.
They are the only 2.
Thailand, Malaysia.
The only 2 photon
counting
CTs
yeah.
are in Mumbai, in Reliance and Breach Candy.
Yeah.
So if you're going to do a CT, you might as well do that.
So the point is very simple. I'll tell you. We've been doing CT coronaries from 2007. As the technologies changed to get better and better. The last CT scanner that we had was a dual source CT, which I said has actually 2 CT scanners in one. And that allowed you to scan at any heart rate, whether the rhythm was abnormal or normal. But the problem was in 2 areas. The main enemy was calcium. So if there were calcium blobs in the coronary artery with a higher calcium score, we couldn't look inside. Sometimes you might have a calcium score of 3,000, 4,000, but we could see the vessel inside because the calcium was all on the wall.
Wow.
But a lot of us who have calcium have it, say, in the proximal LAD, and it's there as a blob. And what would happen with CT? The calcium would actually bloom and be bigger than normal. So it would cover the vessel and you had no idea what is happening below. So there were people with even 300, 400, 250 calcium score who would need to go for invasive coronary angio.
Because it looked too much. It looked more than it
just
was.
covered the lumen. There's no way that you could be diagnostic on it.
So in layman's terms, in the old machines, when you did a CT calcium to look at your calcium score in your heart, the calcium, because calcium is such a non-porous element, covered the vessels. Lumen, even I don't know what lumen is. Covered the vessels, and therefore you couldn't see what was happening behind it. So people had to go in with a, like invasive thing to see what is there.
That's right. Whether there's disease there or not.
Where they might as not have been, but because they were worried, right?
So what photon counting CT does, because it goes from 0.6 mm down to 0.2. Your routine scan is 0.6. This is down to 0.2. It removes the calcium bloom. So I have enough cases to show where previously we did a CT where we couldn't see the lumen, couldn't comment on the lumen. And now you see the lumen beautifully. Because everything is about lumen. If there's enough blood flowing, you're okay. You don't need. They say 70% narrowing is what is the cutoff. Above that, you need to have intervention to be done. So you wouldn't be able to say about that unless you know that the calcium, what is exact.
When did you get these machines, Doc?
We got it 6 months back.
Oh, so then my tests were not done on that. But mine was 0 still, so it doesn't matter.
Yeah, doesn't matter.
I want to talk about what preventative scans should everyone think about doing using a CT scanner.
So the preventive scans, as I said, using a CT scan would be, of course, a calcium score.
What is a calcium score?
Yeah, so calcium score is that when you develop plaques in your coronary artery, they start off as soft plaques. Why? Because that's cholesterol deposition. So it all starts off.
What is plaque?
So plaque is
Everybody knows the plaque on their teeth.
no, plaque, like on your teeth, it's on the surface. That's a deposit on the surface. Now the problem is that this deposit
of
is on the inner surface of your vessel, of your coronary artery.
No. What is plaque means? What does it consist of?
It consists of cholesterol.
Okay.
Basically, what happens when you start to develop coronary artery disease is cholesterol gets deposited in the inner lining of the blood vessels.
Got it.
So that is what is plaque, and we call it soft plaque. Now, soft plaque can actually break off, block the vessel, and cause a heart attack. Or more often, soft plaque just stays there, and with time, the body repairs it and deposits calcium there. And this calcium, which is deposited there, is what is picked up in a calcium score.
And that is the hardening of the artery.
That's the hardening. So, since you're saying about calcium scoring, let me tell you. The main advantage of calcium scoring, in my opinion, is if you have a calcium score of 0.
Right.
If you have a calcium score which is not 0, it means you have coronary artery disease.
Right.
Why does it say that you have coronary artery disease? Because you have got calcium deposited in your coronary artery disease. And the precursor for this calcium coming there was the development of a soft plaque, which is essentially cholesterol, bad cholesterol, being deposited on the inner lining of the blood vessel.
Got it.
And now if you have calcium in your coronary arteries and you don't have soft plaque, you're very lucky, because if you have soft plaque is very dangerous in the immediate period. Why? It can break off and go distally. The blood vessel tapers. So this can then block downstream and cause a heart attack. Calcium, if you have, and it progressively happens, then over a period of time, the calcium buildup can actually grow inside the vessel and cause a narrowing. But that is a more chronic process. So these are the aspects of plaque.
Got it.
Now, when I say to you that calcium score 0 means everything is good, I must tell you that there is soft plaque build up. So there could be times when you've got soft plaque with 0 calcium and you could have significant coronary artery disease. We, in the last 6 months with PCCT, we've looked at this. We have 8 cases of 0 calcium score out of 1,400, 1,500 patients that we've done. Yes, it's a very small percentage. It's a percentage which is less than 1%.
Who wants to be that percentage?
That's the whole point about statistics. Today, statistics drive whether you should do something or not. But if you are one of those 8, it's 100% for you. And these 8 patients had severe coronary artery disease. And they had severe plaque, obstructive plaque, and needed
8 patients out of 1,400 had 0 calcium score, but severe coronary artery disease because of the soft plaque.
Soft plaque, yes.
And in their case, a CT angio would have...
CT angio picked it up because we didn't do only calcium score. We did calcium score plus CT angio. They came for CT angio. So when you come for a CT angio, we always do a calcium score. Or you might just come for a calcium score. So on the calcium score, it was 0. The CT angio showed disease. And these patients went on to receive treatment.
Doc, in your opinion, when should someone do a CT angio or a CT calcium?
I would say at the age of 40.
What should they do?
I would do a CT angio. You see, there's so much talked about radiation, since we're talking about CT angio, radiation. They say radiation causes cancers. What percentage? Huge studies have shown probably if you got multiple scans done in a 5-year period. You got 1 scan done, nothing. If you got multiple scans done over a period of, say, 5 years even, your risk of developing cancer went up by 2%. And that too, it'll happen decades later. So today, if I don't do a CT angio, worried about the radiation bit, and I have coronary artery disease, and I develop a heart attack, what was the point of me worrying about a cancer which might come 2 decades later? By when medicine would have revolutionized so much that cancer may be even treated by a tablet, like the way we're tackling coronary artery disease with statins. What do we know? So I think the immediate has to be addressed, and we have to understand that we have a high burden of cardiovascular disease. We get it 10 to 15 years before the Westerners. We get it more severe. So our focus has to be cardiovascular disease today, and especially in the young people. And that's why I said by 30, they should start to look, have I got metabolic syndrome or not? Get your fasting insulin and your other blood tests done, get a DEXA done, look at your visceral fat. By the time you're 40, metabolic syndrome starts to kick in with the bad effects. And that's why I'm saying in the 40s, evaluate your coronary arteries, and see whether there's any disease or not. Of course, beyond looking at cardiovascular disease, which we have, it's also very useful to see if there's anything else cooking in the body. So from the age of 30s, I would say a sonography of the abdomen pelvis, as we spoke about chest X-ray earlier, is always a good for both men and women. But by the time you're 40, considering the sonography has not shown anything, sometimes it's good that if you're getting a CT coronary angio done, to get a quick run of the rest of your abdomen and pelvis, because you've injected the dye.
Oh.
Of course, a lot of people will argue about radiation, which I would like to also, a myth I would like to try and bust, is that you do the radiation bit I'm not concerned about, but what people are concerned about is what we call incidentaloma, where you pick up other things, cysts, calculi, stones, but you might pick up a tumor. You might pick up something incidental. And very often people come for scans for other reasons, and they pick up something more sinister and incidental. As you mentioned earlier, Steve Jobs, that's what exactly happened. He went for a CT for his kidney stones, and they picked up a neuroendocrine tumor. Of course, it's legendary that he went on to alternative therapies, possibly influenced by his days in Rishikesh. And I don't want to blame Rishikesh, but he went on to alternative therapies and he delayed treatment.
9 months, yes.
And unfortunately, though a low potential tumor, it spread. And unfortunately, cost a very, very important individual's life. I think the world is definitely poorer by him going so early in life.
Yes.
So, picking up incidental lesions, picking up sinister lesions, sitting there quietly. And today we know cancer, very simple. Catch it early, you're good. Don't catch it early, you're not good. So
you're saying when you do a CT angio, do a full body, the same dye used for the whole thing.
That's right. Do a run so you have a full check. Of course, I mean, if you got a sonography run, it tells you nearly 75-80%. But a small thing like a neuroendocrine tumor in the pancreas may not be picked up by a sonography, would be picked up by a CT.
So, and if you do a CT angio, while doing a CT angio, because a lot of people watching this are going to think about doing a CT angio for sure.
They must.
And you want to, along with that, you're saying do the whole body thing. How much more radiation is that?
So you're looking at maybe doubling the radiation.
Got it.
Today, with the photon-counting CT, I want to say, I'm not trying to market it, please,
No.
but just giving you the facts. It's cut the radiation dose down by more than a factor of half. So I'd say it's 40% of a conventional.
Let's just pause. Subscribing here isn't just about supporting our channel. It's about choosing what kind of thinking you want around you regularly. So if that resonates, you know what to do. A lot of people say a CT scan is like 100 X-rays or 50 X-rays or I don't know what number. Anything you want to talk about that?
I think going back to what I had said, that big studies have shown that the cancer risk just goes up by about 2%. All right. Fair enough. Even if it goes up. I mean, the point of missing out disease, missing out a cancer, missing out coronary artery disease is too much of a high price to pay. And secondly, it's not proven. How has this whole thing come about that radiation is bad? Is because they looked at the Hiroshima victims and they found a higher incidence of cancer in them. But there's one major point which is debated across and which is, the argument is very strong, trust me. They received the radiation as a blast. Here, one, you're not receiving that level of radiation, which is 50 millisieverts plus they received as a blast. You're receiving 5 millisieverts at a time, and it's over a extended period of time. The body has a reparative mechanism. You're receiving smaller doses of it. And there is a very important theory which we can't ignore, is known as the principle of hormesis. The principle of hormesis says, for the body to repair better, it needs stresses. This goes back to the old civilizations of ours, where the kings would take small doses of poison to build up their ability if somebody poisoned them, that they would not.
Got it.
So the principle of hormesis says, actually, small doses of radiation every year are good.
Wow.
Good.
And anyway, the truth is, good or bad, we're getting so much radiation anyway from our devices, from everything
You
around
know
us.
what is your background radiation? 5 millisieverts. So your background radiation that you're getting every year is equal to a CT. And are we all and if it was so bad, our hospitals would be full of cancer patients. I really feel it is totally overhyped.
Right.
And the benefit, because fair enough, we might be at the end of the spectrum. We see that. We see it. People refusing to do a scan and then coming into the ER with a heart attack where 30% of their muscle is gone. They're incapacitated for life with an ejection fraction of 30 or 25% and things like that, just because somebody told them don't do a scan because of the radiation. So we have to have a practical approach to it and looking at the pros and cons.
Very interesting. And let's go to the next one, the king of preventative imaging, the MRI. Can you tell us about an MRI?
So MRI is magnetic resonance imaging. It has no radiation. It uses a very, very strong magnetic field. And with that, it's able to image the body. It's fabulous for soft tissue, fabulous for the brain, fabulous for even now the abdomen, the pelvis. It's become very good for even looking at the heart, where sometimes you want to do a stress perfusion study to see under stress how the different walls of the heart are getting blood. So it's very good for motion. It's very good for musculoskeletal joints. There's nothing like it for your joints, for the musculoskeletal system. So it's very, very, very good. Where is it not good? It's not good for the lungs, mainly, and coronary arteries. It can't image the coronary arteries well. So you need CT there. There's no alternative.
A lot of people are talking about preventative part of an executive checkup, doing a full body MRI. Can you tell us what do you think of that?
It's wonderful for the business.
Big money, big bucks.
Wonderful for the business, but not wonderful for the radiologist to start with, and then for the patient. Why? One, you pick up a lot of incidental lesions. The radiologist has to scratch the head, because when you do a whole body MRI, you're going to do it in 30 to 40 minutes. So that means you've done really a screening procedure, not a detailed evaluation. I don't have a detailed evaluation.
Because 30 minutes is very quick, you're right. Otherwise, the full spine is 1 hour.
Yeah. So, it's a very quick study.
Oh, so it's
more like a screening study that you're doing. If you're going to do every region of the body, it's like 6 hours in the machine.
Okay, a real deep one. If
deep one. Okay. So I don't have that type of information. So on that basis, you got to talk about what is that lesion that you picked up, the incidentaloma. Why are people doing a whole body MRI?
The insurance
to know,
pays for it.
Of insurance. So to know, is there something wrong? So they're anxious. You can't say, we see something. Maybe let's see 6 months later what happens to it.
It may grow.
So the onus is on the radiologist in a huge way. We're not shying away from it because of that. And obviously for the patient, it's stress if there's incidentaloma. Second, I go back to my fundamental point. What are we looking at in our population? Cancer or cardiovascular disease? Where a whole body MRI can have a value, is detecting early cancers, not cardiovascular disease. So our focus has to be what is our primary burden. Yes, The West is seeing much higher cancers than we are. We will see. We can transit at that time. At that time, there may be new technology, different technology, better MRI machines, faster, more accurate, whatever it is. But at the present time, our focus has to be cardiovascular. So that is why whole body MRI, somebody wants to do, welcome to do it. But I wouldn't say it should be a real priority unless you have a family history. I feel targeted MRI is very useful. Where MRI is very useful in preventive imaging, I'll tell you, which is what we are very fond of, is that when you have metabolic syndrome, fat gets stored in the liver also. So when fat gets stored in the liver, it leads to what you call as non-alcoholic steatohepatitis, which leads to cirrhosis of the liver.
Oh.
Today, we have a higher incidence of cirrhosis of the liver from fat in the liver than alcohol.
That's fatty liver.
Fatty liver. So fatty liver can lead to fibrosis in the liver, cirrhosis.
Which you normally hear cirrhosis means you are an alcoholic.
Alcoholic.
Cirrhosis, someone said that.
So now the whole thing, percentages have reversed. It's mainly what we call NASH causing cirrhosis of the liver. And that leads to, as you know, liver failure, and then or can get liver tumors because of that. And then people also get liver transplants for that. So I'm not saying that everybody with fatty liver is going to get a liver transplant. A very small percentage, but it can progress. So you need to reverse it. You need to pick up the fat in the liver, which a sono may pick up, which a CT may pick up. MRI is very useful for fat in the liver. It gives us an exact percentage of how much fat there is in a liver. Normally 5%. So if it is high, you know you can reduce it. And more importantly, we have something known as MR elastography. It started with a fibroscan, seeing how stiff the liver is, because that's what happens. The liver gets hardened when you get fibrosis, and fibrosis is not reversible. Gets hardened. So they had fibroscan, then they started using sonography for it. And now we use MRI. So we can give you an exact fibrosis thing. And what is great about medicine, nothing is hard and fast. Clearly in the books, you'll see if you have got fibrosis stage 4, it is irreversible. We are now seeing people doing lifestyle, and that fibrosis level is coming down from stage 4 to stage 3.
Wow.
So medicine, nothing is really written in stone. Things change with time, and we keep learning.
So 2 things there, Doc, that stood out for me. One is you're saying that the amount of people getting liver cirrhosis from fatty liver, from metabolic syndrome is higher than people who are alcoholics today.
Yes. Yes.
Very interesting. And the second thing is, so then, should someone do any preventive tests for the fatty liver? Isn't it so dangerous?
So when you, as I said, in your regular checkups, you do a sonography. The sonography will pick up fatty liver.
Got it.
And if you have fatty liver, ideal would be to get to know what the percentage of fat is in your liver. Then that becomes a baseline for you to bring down your fat percentage, as MRI, no radiation. And if your fat percentage is high, useful to get an MR elastography to see, are you going into fibrosis or not?
Could you tell us another version of people who don't do this and what happens?
So 2 things I'll take, not one. One is a very interesting statistic. Coronary artery disease is higher in marathon runners than non-marathon. So I have so many people who come to me, say, I'm super fit. I don't need all this. Look at me, I'm super fit. I run 10 kilometers. Look at six-pack, look at this, look at that. And I've actually had a friend who would sort of bait me to say, hey, what? Yeah, you guys, CT angio, you'll push this, that. Look at me, nothing can happen. I said, look, it can happen to anybody. It happens to marathon runners. It happens to people who go to the gym regularly and are fit and looking fab. It happens. There are enough celebrities to which it has happened. So there's this guy who would actually enjoy baiting me about this socially. And one day I get a call from his wife. So come, where? Say he's in the EMS. He's had a massive heart attack. And now what? He's lost muscle tissue. He's going to be incapacitated for the rest of his life.
He's going to be incapacitated for the rest.
Incapacitated because his ejection fraction 30. He'll go on to medication, Vimada, this, that, cardiac rehab.
So it was a bad one.
Bad one. Of course, the guys who you lose, you don't know the story. But this, at least you have a story here. So it's...
And he was a marathon runner.
Well, he wasn't a marathon runner, but he used to run 10 kilometers every Sunday.
That's a marathon runner. For me, that's a marathon runner.
So, as we were talking about MRI in preventive imaging, something that I am very fond of having done is once in your lifetime, and as early as possible, is to do an MR angio of your brain vessels.
My God.
It's without contrast.
Oh, without contrast.
It's without radiation.
I was like, oh my God, one more thing for me to do.
It's a quick study, and it tells you very importantly whether you have any abnormality of your brain vessels. Why I say abnormality? You can have from birth a malformation. Either what we call an aneurysm, which is an outpouching of a vessel, or you get a vascular malformation. The problem about these is as you grow and as your blood pressure rises, which will rise as you go on in age, the pressure can rise and these can rupture. And when these can rupture, it can be catastrophic. And you could have an entire spectrum. They can present with you can present with symptoms, which are like headaches. But headaches, everybody gets headaches. So so that's why I feel once in your lifetime, do that. And I can tell you that they're fascinating. I mean, I've seen so many people with this. I can just give you parts of the spectrum. There's a chap that you know very well and I know very well. And I came one Monday morning and sat to start my reporting. And I saw his name. How come he came? He didn't tell me he's coming. Then I saw it was at 3 a.m. I said, 3 a.m., why did he come? He said, no, he was complaining of headaches. Oh, headaches. I called him up. He said, what happened? He said, no, I had some headache. Now it's passed off and it's okay. I said, no. You come here. I want to do your MR angio of your brain. He came. Very sweet boy. Came. We picked up an aneurysm. A ticking time bomb. He got that coiled. Then you have the group where there's no time. So there's this school friend of mine, lives at Kemp's Corner, calls me at 7 o'clock in the evening. My wife is having severe headache with vomiting. She had symptoms, no doubt. Come in immediately.
Could have been a migraine,
Yeah. Come in immediately. So we do an MRI. There's an aneurysm out there and it's ruptured. Oh. The brain is full of blood. She was brain dead. So you see, it doesn't give you any time sometimes. So that is why I feel, as I say, you got to look at the pros and cons. Somebody will say, are you crazy doing an MR angio? But if you had an aneurysm like this friend of mine and it got treated, it's not like this one, not detected, came in with this issue.
Wow.
The third group are the ones who are not fortunate, who are left as vegetables because they've had a stroke because of the bleeding, they've had that. So the consequences can be terrible. So that is why I say once in a lifetime, as early as possible, do an MR angio. I am severely claustrophobic. I've been putting people into MRIs from 1989. Nothing happened. Go on.
Shame on
nothing. Finally, we got a lovely MRI, which was very wide, had light in it, had a TV in it, had music in it, and everything like that. And I did my first MRI. And what did I do? My MR angio. I was desperate to do it because of what we see. And once I got it done, I was so relaxed and happy.
Your wife will say that now you know you have a brain.
I think she already knew.
Okay, small pause. This is the part where I'm supposed to ask you to subscribe. But honestly, only do it if you want more conversations that actually make you think. That's the whole point of the secret sauce. All right, back to it. So the question I would have if I had to do a brain MRI, which I'm thinking about now, obviously, thanks to you, is that what about the incidental findings? Wouldn't there be too much random stuff, like, oh my God, and you're going to get paranoid, like whatever, like who knows what's in your brain? I don't know.
Incidental lesions in the brain, very rare.
Right. It's not like your heart and your stomach and all that stuff, right?
And if you want, we won't tell you. how your brain is.
Yes, yes.
We'll just tell you your vessels are okay, you don't have an aneurysm.
Yes. That you're the expert at. Everything is fine. Everything is fine. Right.
But things are actually even better since a year with us because we got a new technique known as deep resolve. So it's an AI-based technique and which actually speeds up the scanner's time as well as the data acquisition. So the images are crisper, better, and the scan times are down to 40% or 30% of the regular time. So now if you come for a spine, you'll be out in 10 to 12 minutes.
Wow. And I spent 1.5 hours. So they had to do something twice. Some shit happened. I know we've touched on this before, but I just want like a clear, a large part of this podcast is actionable insights for everyone. And that's why it's so amazing to have you, honestly. I have learned, again, even though I've met you 100 times in the hospital, I've learned more stuff about what I have to do and not have to do in terms of preventative imaging. So I just want, to create a clear protocol on what you recommend for people at different ages on what you think they should do. What should a 30-year-old Indian do?
So 30-year-old Indian is at the cusp. He's at the cusp of the start of metabolic. He or she, absolutely. So first, of course, is you do your routine investigation, routine blood test, routine chest x-ray, ultrasound, abdomen, pelvis, because it's so easy to do just to pick up anything incidental. So the basic thing would be that at 30, what would be the thought process of the investigation? The routine basic plus looking, is this an individual going into becoming metabolic, going into metabolic syndrome? So the blood test, fasting insulin, lipo A, ApoB. And on the imaging side, visceral fat, DEXA with visceral fat. I think this at a 30-year-old would be more than enough. The thought process being simple.
Got it. 40.
40, now the chances of metabolic syndrome kicking in are definitely there. So we would repeat whatever was done at 30. If the lipo A is done, you don't need to repeat it. But repeat everything else done at 30. And here I would add in, if there's fat in the liver, quantifying the fat in the liver, okay, with MR, as well as doing a calcium score plus or minus a CT angio. If the calcium score is 0, we could skip the CT angio, but I'm always in favor of doing a baseline CT angio. If you're 50, that's when you're going to start to want to look at adding. So the thought process, 30, are you going to be a metabolic syndrome candidate? 40, do you have metabolic syndrome? 50, if you have metabolic, do you have, and what are the effects of it on your cardiovascular system? And at 50, start to screen for cancer. Extend your CT to cover your abdomen pelvis.
What should you do?
As I said earlier, CT coronary angio. And because you've given the dye, just extend the scan to include the abdomen and pelvis.
Got it. And what about like a colonoscopy?
So colonoscopy is very controversial in India because our incidence is much lower.
Right.
Our incidence is 1 in 10 of Western. We're 10% of Western. Some studies may show 25% of Western. But we definitely have a lower incidence. Their problem is polyps, and those polyps turn malignant.
Right.
We have less of that problem. So colonoscopy doesn't be so important. As I said, our focus has to be different, which is cardiovascular.
And this a CT angio of the abdomen after 50. So every 50, 60, 70-year-old should do a CT angio of the abdomen as well as the upper body.
Yeah, it's a CT angio and then just the run. It's not an angio of the abdomen.
Right.
It's just a screening of the abdomen organs.
Because the dye
because
goes
the dye is there. So any abnormality gets enhanced.
Got it. What do you think is missing in executive health packages today?
So I think executive health packages, it's very varied. You have the 90 test blood packages, which are not 90 tests. The CBC is 21 tests, which is actually a CBC. So that 90 is actually 11 tests.
Right.
So what, in addition is, as we've discussed today, so a lot of executive health checkup packages have inclusions, have exclusions. So I think things to me need to be more comprehensive.
And also there should be an age point to it. Like if I'm a 30-year-old person doing it can't be executive health checkup. Yeah. So what age of an executive
am I? So I think the executive health checkups need to be a bit tailored.
Right.
And I find that certain of them are called executive health checkups, but don't include important tests because they don't have the equipment. So I think it's very important to have a tailored and to see that it's comprehensive, covering everything.
Seems to be that there's no question, because for many people the executive health checkup is blood tests, easy to do. Someone comes and takes your blood, but there's no question that your executive health checkup has to include you going somewhere. I'm talking about on a very practical level. You're going to have to go somewhere and get some physical test done. So whether it's a sonography or a DEXA scan or a CT or whatever the hell it is, but it can't just be blood tests.
Absolutely. No question about it.
I mean, I'm just saying, because for a lot of people, it's like they're happy to, blood test comes and goes.
Very good.
Nobody wants to go anywhere. You know how it is.
I got 100% results.
Yeah, exactly.
So when you say about the executive health check, what is more required? And I think that's something which is not done actively, but is getting popular and actually is very important, not related to imaging, is a VO2 study, which is a study done on a treadmill, which actually looks at your breathing, how much oxygen you're taking, and how much carbon dioxide you're throwing out.
Right.
Why it's important? It's a very good predictor of your heart active function, your lung function, your blood transportation system, and it's actually a predictor for longevity. It's a predictor of disease happening. So it's a very good test which needs to be introduced. It's a simple test to do.
A stress test.
It's a stress test with an oxygen mask. So it's
yes.
measuring how much oxygen going out and in. And I think that is something that we'll see added to health check programs, which will be of great value.
Yeah.
Because as we're growing older, we need to look at our muscle strength, our core muscles, our balance, and other things. Of course, we're going ahead.
Yes. No, I know that one.
Yes.
You're running and you have the other thing on. It's a bit weird. I've done it, but yeah. There's an interesting new phobia called cyberchondria, which is when people basically get a scan report and they Google every term, and now, of course, they'll use ChatGPT or Claude or whatever. And people will use 3 AIs now and convince themselves that they have like 6 different diseases and trip out about it. How do you manage that with your patients?
So this is a totally common syndrome today.
Yeah.
And it is like, it's crazy. I have a friend who had a shoulder problem. And every time she'd message, okay, now I have this. I need this scan done because I need to find this out. I need to find that out. Fine, we do the scan. And it's obvious, okay, from the symptoms, you have a rotator cuff, which ChatGPT can tell you it's rotator cuff. And then you come and you do the scan. Then the scan is dissected down. Okay, it has this tear, so I need this to be done. I need that to be done. And who is telling you to do all this? You have a minor tear. You're nothing. Just do physio, just be this thing. No. Who's telling you? ChatGPT.
Yeah.
And today, apparently, ChatGPT tells you about your emotions, about everything. So it's crazy.
Yeah.
But I'll go one step back. In medical school, it's a very common syndrome, especially when you're studying psychiatry or you're studying any disease. Medical students simulate that they have the disease because of when they're reading the symptoms. Oh, I have a similar symptom. Oh, I have a little headache. Oh, I have this. Oh, I have that. So
that's
these
so
things.
Because I feel the same. I am sitting here every week with doctors and all, and then it passes. But halfway through, like with you also, halfway through, I thought I'm going crazy. I'm hearing all your things, and then I'm like, okay, boss, take it easy. Focus out here. So it's a human thing basically to associate with the
human thing. So it needs to be curbed because it just creates so much stress. It creates unnecessary. It's useful, no doubt, but reliance on that. I have times I can show you my ChatGPT where I've written to ChatGPT, you're wrong, and ChatGPT has written back to say, you caught me on this.
Yes. Thank you for catching me.
Thank you for catching me. And what about those who did not say,
Yes.
So there is, information is very important, but it has to be filtered. It has to be evaluated and looked at the pros and cons of everything.
It's true. Like you spoke about, everybody used to Google it before, and now the new Google is AI, which is a Google on steroids. So let's talk about AI a little bit. Not from the patient side, from the technology side. especially for you, because you are really at the intersection of technology and medicine. Where do you think we are today with AI, and what does the future look like?
So, as we take the term artificial intelligence, I'll be very brazen and say it's been hype for the last decade. It's still hype. But I wrote a piece, which I don't know if you had researched, but doesn't matter, is I said AI, artificial intelligence, or augmented intelligence. And that's what I call it, that artificial intelligence for imaging is augmented intelligence. It's helping us tremendously. As I said, MRI, it speeded up the scan time, improved the image quality.
Amazing.
Like say you have a TAVR study. Today they replace valves with a catheter. They require an immense number of calculations of the diameter of the vessels, whether their devices can go in, this, that. All that is automated by AI. It has, you get your work lists, you get measurements, you get densities. So a lot of manual work that we used to do, which any manual work can be fraught with wrong results or inaccurate results, has got automated by artificial intelligence. So it's really augmenting us. Now comes the basic question, which is in everybody's mind. Artificial intelligence will replace the radiologist. No. Which radiologist it will replace? The guys who do teleradiology. The guys who sit in front of a computer, what they see, they put down. Yes, maybe 5 years from now, it will replace them because it will list the findings. But that goes back to your basic question. If you have incidentalomas, you will have triple the list of incidentalomas. It's like all these AI companies which are doing chest X-ray. The ideal time for them was COVID. Just detect COVID, no? They failed. Today, your positive predictive value with the best AI company on chest X-ray for a single disease like tuberculosis, positive predictive value is 54%. Yes, it will tell you that there is something there. But it could be a tumor also. It could be anything else, could be a pneumonia. How do you differentiate? And this is where imaging is different. So if you are a radiologist who will sit in your armchair with your coffee cup and your screen and be cut off from the rest of the world, will dictate your report, you have a danger to become irrelevant in the AI age, which may come in 5 years. But if you are what we call, and I say all radiologists should be a clinical radiologist, and which has helped me tremendously, is continuous communication with clinicians. Right. After all, what are we? We are communicators. What we see, we need to communicate to the clinician. I see this. It's for them to decide how much of value that is. And that's how you cut down incidentalomas. Secondly, as you communicate more with them, you obviously imbibe information. So you learn yourself that this is important, this is not important. What are the symptoms a patient has?
You have to correlate.
You have to correlate. So where the teleradiology boys are sitting totally cocooned away, and they are in danger of going out of the window. But if you're a clinical radiologist, AI cannot replace that clinical acumen.
Where does AI genuinely beat a trained radiologist today?
At best, it will reach a trained radiologist, not go beyond. Right. There are studies which have been done which have basically shown AI beating radiologists, but those are trainee radiologists.
Trainee radiologists, right.
So if you look at all studies, you'll see that AI doesn't beat a trained radiologist at present, as we speak.
Got it. India's diagnostic market, according to a report, is going to be $43 billion by 2032. What does the next 10 years look like for imaging in India and in Breach Candy Hospital?
It's just going to be explosive.
Yeah.
There's no question about it. It's so underutilized till date, and it has the benefit of technology moving. It has the benefit of AI augmenting us, helping us. So I think it's a golden age, and things will just get better and better and better, and better for humanity.
Got it. Your hospital, British Candy Hospital, is a legendary hospital. People from all over India have come there. Presidents, prime ministers, CEOs from Bombay, of course, but from all over India. These people could have gone anywhere. What is the secret sauce of British Candy Hospital?
So I'm a little biased. I've only really worked in 2 hospitals in Mumbai, Jaslok for some time, and now basically Breach Candy. But what I can tell you is that the hospital is a very different place than anything else. When I took over as a CEO, I thought, okay, now, like it's like a hotel, things like that. No, it's totally different, a hospital. Nobody comes out of choice to a hospital. Everyone goes out of choice to a hotel. A hotel knows when people are coming and going. A hospital never knows when somebody's coming or going. The fact that they're not happy being there, they don't like anything. They don't like the food. They don't like the linen. They don't like anything. What Breach Candy Hospital has fortunately had has been clinical excellence. The top doctors, no question. Highly ethical, highly professional. And what it has is a fabulous nursing staff, which has empathy, numero uno, clinical efficiency. And these, in a nutshell, are very important to have clinical excellence and to have empathy, compassion, because the individual coming is coming not out of choice and his body language is not good. You need to do something to keep them calmer, happier. And it's well proven that if you have a happier patient, they do better.
What technology excites you the most currently in your hospital and going ahead?
I'm obviously technology driven. So now in an admin position, I am looking to push technology. I briefly spoke about VO2, things like that, bringing in other things. But one technology early that we brought in, which actually fascinated me, was that there were 2 IIT boys who came to me and told me that without touching the patient, we can tell you heart rate, respiratory rate, blood pressure. I said, how? I mean, this is like the movies where we used to see where they used to touch the pulse and say that the lady is pregnant. So, it was like that. I said, how is that possible? It's not possible. So I said, all right, demonstrate to me. And it's quite amazing. Today, every bed in Breach Candy is what we call a Dozee bed, because Dozee is the system. It's a very simple system. Every bed in Breach Candy is a Dozee bed today. Right. I'll tell you. What is Dozee? Of course, we started with 10 beds, 20 beds, and then when we thought, we expanded it. What does Dozee do? Dozee is a sensor which detects pressure very sensitively. Of course, you have AI involved in it, helping to magnify the signals. Yes. This is kept below the patient's bed. The patient is not in contact, not aware. There's a device to which it's sending the signals. And you have a monitor at the nursing station. You can have a monitor in the room also, and which gives the respiratory rate, heart rate, and blood pressure. Now, why is it so important? Because when a patient is in the ICU, they're monitored. What about in the room? There's no monitoring. Of course, you don't put people in the room if they need monitoring. But what if something happens? And if something happens, we call a code blue, where you come in with an ICU team, come in and resuscitate. If we can reduce code blues, it's very important, because not everyone who has a code blue resuscitation is left without any neurological deficit or something like that. These things happen. So here we have monitoring the patients. We have a command center in Bangalore, because we know that there's nurse fatigue. There'll be alarms ringing, put the alarms off. So we have a command center in Bangalore, which has predetermined levels, heart rate, respiratory rate, blood pressure. And if there hits one of those critical, the call comes to the ward. If it's not answered, it goes to the ICU. And if it is of a very low critical alert, directly goes to the ICU, so that people come in and check. One benefit that I found as an administrator at a busy hospital like Breach Candy Hospital, I knew if a bed was empty and I could get another patient in, because if there was no Dozee data coming. Another area which we formulated with Dozee was what happens. Patients are in hospital, they may be sedated, they may be on medication, and they get up at night to go to the loo and fall and fracture. And as you know, in an elderly, a fracture is usually the start of the downward spiral.
Yeah.
So what we do a fall risk analysis. This one has more chance. We're on sedation. We have to watch this, that, all that permutations, combinations go on. But here we said, in addition, if this patient is a high fall risk, put a Dozee alert for fall risk. If they leave the bed, immediately the nurse knows that this person has left the bed. And we have caught a couple of patients in the middle of the night before they fell, that the nurse has got the alert, this person is no more in contact with Dozee.
With the bed.
And the bed. So, a lot of fabulous technologies coming in.
And do many hospitals have this Dozee?
So, yes, now we are seeing hospitals adopting it, Apollo, Reliance, other hospitals. It's now going to the Middle East, it's going to America. It's an Indian product, made in Bangalore.
That's very interesting.
India for the world.
Amazing. And you were the first hospital
We were the first.
in India to do this product, right? If someone listening to us right now could do just one scan that they have never done before, what do you think they should do?
So the one scan, I think our focus is really metabolic syndrome and preventing cardiovascular disease. So when you're early, get a DEXA scan done to know your visceral fat. Are you in risk? 40, start looking at your coronary arteries.
Got it.
So should I tell you my journey? I was in the mid-40s. And I was slowing down, I thought. I was starting to feel a little sleepy in the afternoons. I love working a 12, 14-hour day. I was putting on weight. And I was just not feeling good. And my wife said, it's midlife crisis.
Of course.
You're getting bored. You're doing the same mundane thing. This, that. I said, no, I'm not good. I met endocrinologist after endocrinologist out here. No. They told me the same things. Exercise, diet. But why? What is wrong with me? But why? And luck so happened that my dad needed some work done in New York, medical work. And Malvika and I went with him. And there he took me for dinner with an very close friend of his daughter who lived there. And her husband was there. And he introduced himself to me. I am Noel McLaren. I said, 1 minute. You're the guy who's written all about metabolic syndrome in NIH.
Right.
So he said, yes. So I said, look, I want to talk to you later. He says, I know what you want to talk to me about. So I said, what? You have metabolic syndrome. How do you know? I've seen how much orange juice you've been drinking. I'm seeing your sugar craving. And he explained to me, the thrifty gene and everything like that. And he put me on metformin. He told me, go, control your diet a bit, do this, start exercising. I started doing that. I have a fabulous picture which Malvika used for my invitation for my 50th birthday party, which was just about 6 months later, me coming out of the water, like with a six-pack in Mexico. And I mean, that's where I was. And then with work and stress, with this, you lose your way. So that's my journey with metabolic syndrome. And that's why I think it's so, so important. What it did to me, I had people who started to ask me, like some friends of ours, great doctors, what's happened to you? You're like, you were 20 years back, so sharp, so quick. So it changes your life.
Yes. Both ways it changes the life, right? Now, like you gave a very good anecdote on your journey, on your metabolic journey, and how in your 40s you were going down, but you've kicked that because there was a metabolic problem. What do you do in your life to keep yourself healthy, fit, sane? Because you are juggling two things. It is a high pressure job. You are the CEO of one of India's most famous hospitals.
So let me tell you, frankly, I am now back to what was I in mid 45. Right. I need to work on myself. The last 2 years have been very busy. I've just not had time And I think we've managed to do quite a lot of good things. So good. So now I need to really focus back on myself and get myself back in shape again. So I'm definitely, I have slipped and I need to correct that. I also want to add that when I talked about, since you raised the mid-40s, and I said, as my wife told me, it's just a midlife crisis, I did try to solve it on her advice, and I bought a red 2-seater convertible.
Which one?
But it was a Sandstorm, which came out of Goa.
A Sandstorm, right?
Yeah, and I did, but it didn't help.
It didn't help. Would you still be a doctor if you could do it all over again?
Absolutely. 100%. And I think, as I said, my decision not to become a physician and to become a radiologist was absolutely perfect. To become a CEO, I'm not sure. I will be able to answer that only 5 or 3 years later once I quit, whether it was the right or the wrong decision. But becoming a doctor, absolutely. But every profession has its pros and cons.
For sure.
So I don't know whether this is a fact known or not known, but it's very important to me because I got a livelihood from this. And I know you like music. The Beatles.
Fantastic.
I don't know if you know this. Okay. Godfrey Hounsfield, the guy who invented CT, used to work at EMI. EMI was a big company, had multiple different verticals. He wanted money to build a CT scanner. They said, no, we don't have the money for that. Do some other research. EMI had a recording studio known as Abbey Road.
Abbey Road, yes.
The Beatles used it later in their career. And EMI made a lot of money from Abbey Studios.
Yeah.
And when they made that money, they went to Godfrey Hounsfield. You wanted money? Here's the money. And that's how he invented CT scan.
Wow.
So we have CT scan because of the Beatles.
Amazing. They were the greatest and they are the greatest.
I mean, I got my livelihood because of them.
And a lot of pleasure for all of us.
Yes.
Thank you so much, Doc. That was really fantastic, fascinating. And I'm thinking of the test that I have to do now. Thank you.
Thank you.